Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good evening, everyone. This is Suhail Abdullah from Dubai. I'm a stroke neurologist from Dubai, and I'm welcoming everyone tonight for the first webinar that we are conducting for 2021, which will be a serial of webinars that we are doing as the Middle East North Africa Stroke Organization going to host. As the first webinar for this year, we are looking for a great speaker and a great chairperson that we are going to have. Before we start, I will ask everyone that we will have an icon of question and answer that you can send to the group. Today, this webinar will be chaired by Dr. Syed Irteza and Dr. Adnan Al-Qurashi. Professor Syed Irteza is a consultant neurology and an intervention neuroradiologist. He's the head of Department of Neurology at Neurological Institute at Cleveland Clinic, Abu Dhabi. Dr. Irteza Hussain is a consultant neurologist with experience of more than 20 years in neurology. He graduated from Aga Khan University and did his training at Michigan State University, where he did his postgraduate in neurology, vascular neurology, neurocritical care, and endovascular. Dr. Hussain has more than 2,000 cerebral angios and endovascular procedure done over the last 17 years. Currently, he's an active member in the UAE community in Abu Dhabi and running one of the best neurology and neuroscience neurovascular center in the Middle East. Our second chairperson is Dr. Adnan Al-Qurashi. Professor Adnan is a distinguished speaker from the US. He has more than 20 years of experience in neurology and stroke neurology. He's a neurologist from Columbia, Missouri University. Dr. Adnan published many papers in the past, and one of the recent papers that he published was about the COVID and stroke, which came early last year as one of the distinguished paper in the era of stroke and COVID. I would like to welcome both of our chairperson, and we will start with the first speaker. I would like to ask Dr. Maria Khan to share her windows. So this is what we are planning to do. We are going to have, in a monthly basis, a city that will present from Middle East their challenge cases in stroke. This time it will be from the dream city, which is Dubai. Dubai is the second largest 7 Emirates from UAE, and it's a home to nearly 200 nationalities. Next, Maria. Dubai is a very active city. You can see Dubai in 1990, where Sheikh Zayed Street was there, and now it's full of towers and very active city. We wish all of you to be able to visit Dubai soon. Emirates Airline is one of the best or airline that you can use to get to Dubai. After COVID, everyone is welcome to visit Dubai, inshallah. We can start Maria now. So our first speaker is Dr. Maria Khan. She's a board member of MENASO organization, and she's the national coordinator for SITS MENA registry. Maria is very active member in our team at Rashid Hospital, and she had a numerous publication in the area of cerebrovascular and stroke, and she will start the first case. Please, Maria.
Okay, so Assalamu alaikum and thank you. The idea behind the case presentation, we understand that we have, I think, close to 900 people who've now joined this meeting. And what we are hoping is that everybody should be able to take away something from this case discussion. So there would be centers that are that are just starting off with stroke care in the region. So we want them also to get a taste of acute stroke care, and there would be centers that are already doing a lot more than actually what we are doing at Rashid, and we would love to hear their views on management aspects. And for that reason, we are very happy that Dr. Irteza Hussain and Dr. Adnan Qureshi were able to join us to share their experience with us. So without further ado, I'll get into the first case for today. So both of these cases, actually, they are very recent admissions. We saw them last month on our service. And the first one is a 33-year-old Indian male. He's known with diabetes and hypertension. And because of this COVID situation and there are a lot of issues around that, he was not able to get his medications, and he had stopped taking all medications about 3 weeks prior to his presentation. He went to sleep normally at 10 p.m. He woke up at 8:30 the next morning, and he woke up with a right-sided weakness. He presented to the emergency at 11:22, so almost 3 hours from the time that he woke up. For the rest of the history, he denied a headache or a neck pain. He denied any history of trauma or neck manipulation. He was a non-smoker, and there was no history of alcohol consumption. In the emergency, the vital signs were almost normal. He had a heart rate of 85. He was afebrile. His blood pressures were all right. Just the diastolic was about 102, and he was maintaining SATs on room air. He was alert. He had a partial gaze palsy. He had a right partial hemianopia, mild aphasia. He had a right-sided facial weakness, and he had a very dense right hemiparesis. His NIHSS with all of these deficits was about 13. So the major deficit was the hemiparesis, and there were milder deficits in the other domains that I just mentioned. I'll go over the CT for him. So just for the audience to keep in mind the timelines that we are talking about. So this is the CT brain that was done on arrival in the emergency, and it was done at 11:30. So within like 10 minutes of his emergency arrival, and we could see a sort of a hyperdense MCAs, but not really asymmetrical. And then there are some early ischemic changes in the top cuts that we could see over there. As per the protocol at our hospital, he underwent a CT angiogram alongside this CT brain. And the CT angiogram basically had interesting finding. So, sorry, let me just stop it over here. Okay. So we start to see a partial occlusion of the left common carotid. And if you keep following it up, this thrombus seems to extend into both ECA and ICA. And then more distally, the vessels were clean. So he was perfusing, both the MCAs were filling up nicely, and we didn't see any major occlusion intracranially. He did have an area of oligemia in the top cuts. And I'll just put the sagittals for you to appreciate that thrombus I was just talking about. So this is the left one we are talking about. And sorry, here. So he had this irregular filling defect starting in the left common carotid and extending to both the ECAs and the ICAs. So at this point, I'd like to get in my other moderators involved. We have this patient who's presented as a wake-up stroke. He's about 3 hours from the time that he woke up, but his last known well was almost 12 hours ago, more than 12 hours ago. So the question that comes to mind is, should we be considering any sort of acute intervention for this patient? And what investigation, if any, would we go to next? So maybe Dr. Qureshi could comment on that part.
So yes, so this is Adnan Qureshi here. I think that, clearly this is a patient on whom, if we assume the last known normal, so it would probably be beyond the 12-hour time interval. And essentially, one of the things that we've always struggled with is there enough viable tissue to actually consider doing an angiogram and possible intervention? And there are several ways to make the determination. One is actually simply using the plain CT scan and perhaps using something like a semi-quantitative scale like the aspect scale, and using that to determine the amount of tissue that doesn't or does not show early ischemic changes. For most clinical trials, a higher level of imaging has been done, which is actually using the computed tomographic perfusion scans and actually looking at the amount of deficit in terms of the cerebral blood volume, which in most part kind of denotes irreversible brain tissue or irreversibly damaged brain tissue, and looking at the cerebral blood flow or the regional cerebral blood flow to see if there is a mismatch. And in an ideal world, a emergent MRI to actually look at what you can see on the diffusion weighted MRI and kind of conclude that that is irreversibly damaged tissue, and looking at the MR perfusion to see what area is at risk. So I think that that's the next question here, that should we actually get a additional set of imaging to see what is viable tissue and what is not viable tissue, and whether there is enough viable tissue that we can demonstrate on these imaging to actually move forward with an intervention.
Okay. So that was also the question in our mind. So like you very rightly mentioned, I mean, we could be looking at a CT perfusion imaging, or we could be looking at MR diffusion perfusion mismatch, or just based on the CT findings, just take him for a conventional angiography. So given our situation, the aspect score was about 8 or 9 for us. He had an NIHSS of about 13, and he woke up, I mean, we were already almost 4 to 4 hours from the time that he was found in that state. So we took him directly for a thrombectomy, and an aspiration thrombectomy was performed after a diagnostic angiogram with the penumbra aspiration device. And I'll just share with you some of the pertinent images. So he had like a dirty looking sort of a carotid thrombus that was sitting there. These are pre-images. And then he had a good distal flow. And then following the penumbra suction, they were able to sort of reperfuse a little bit better. The area looks better, but he still had some area of stenosis that was residual in this carotid. There was, again, like we saw in the CT angiogram, no intracranial stenosis that was seen. So I'd appreciate comments on the intervention. Maybe Dr. Irteza, you could take that question. Should we have considered doing a stent at this stage? Post-intervention, the patient's NIHSS was 8. We did not do any sort of stenting. There was only an aspiration thrombectomy, and we stopped there. So Dr. Irteza, please.
Yes, this is Irteza here. First of all, quickly, thank you for the opportunity to talk and to actually share the platform with one of our mentors, Dr. Qureshi. It's always a pleasure to learn from him. So overall, I think one principle for the audience that we want to make clear that this is an extracranial carotid thrombus. Intracranially, the central arteries were open, even on your baseline CTA, and we don't see it on the DSA, but I'm presuming the thrombus was actually extracranial, starting in the CCA, and then intraluminal thrombus kind of occupying the origin of the ICA. And if you look at the baseline CT, the aspects was high, and we do not have a central occlusion. So, and if you go by the clinical exam, there's clearly a clinical imaging mismatch here. And this patient is presenting with perfusion failure of the hemisphere. So yes, if we look at the data, yes, this was an expanded window, 12 hours, and getting an assessment of viable tissue and the extent of the so-called core is what you would do under normal circumstances. But I think what was carried out here is also another completely rational approach. In the acute intervention phase, we typically would just reestablish flow. And so after aspirating this thrombus, you've reestablished flow. You've confirmed with your post-aspiration that there's no intracranial occlusion. At this point, we would likely stop, see how the patient is doing clinically, and then also, since we didn't have any imaging before, get an assessment of overall what the ischemic burden is. Typically, intracranial stenting in the acute scenario, we've shied away from it for a variety of reasons. You're not sure how big the core is going to be. Maybe you have TPA on board and now you're going to stent. So as long as there's no luminal, as long as there's no severe restriction of antegrade perfusion, we typically would stop here and live to fight another day, get some more assessment, and then usually I would prefer delayed stenting in this scenario. So I actually agree with the approach that was carried out and be curious to see how the patient fared.
Okay, so thank you. So moving on, the next day, the patient did undergo an MRI brain, and what you have here is a diffusion and a flare image. And this had another surprise for us. So we did see this rather moderate sized stroke on the left side, but then we had some diffusion positive areas on the contralateral side as well. So at this time, again, the question was, he's only 33. We know that he's diabetic and hypertensive, but these bilateral strokes made us think, we know that the other side of the vessels on the other side are all normal. Are we looking at cardioembolism, or is there another explanation for this? So we did actually entertain the thought of another anatomical explanation for this. And we went back and we reviewed the images. And one of the things that we thought of is the fact that both the ACAs seem to be arising from the left side. And there is a very small sort of contribution that's coming from the right for the ACA. And if you look at the strokes in the previous image, they were actually all, they seem to be high parietal, the ACA territory strokes. So that was one possible explanation that could explain why it was the same thrombus, we believe, that part of it embolized to the contralateral side. So that was one thought. But then, of course, we had to evaluate him for cardioembolism as well, given his age and the kind of stroke and the kind of thrombus burden that we saw. He did undergo all the other young stroke workup, and we did not find anything positive in the vasculitic screen or the thrombophilia screen. Everything else was negative. The vascular risk factors, we understand they were quite uncontrolled. His A1C was 9.4. He had a triglyceride of 239, and the blood pressures in the hospital, they were not too high, but they were ranging between 140 and 160 systolic. So he is somebody who was at risk of atherosclerotic disease. We know that. The cardiac investigations that he underwent, we did a 48-hour telemetry in hospital, which is the norm, and it was normal. We did a transthoracic echocardiogram in addition to a transesophageal echogram, and nothing significant came out in either of those. We were interested in exploring what happened to this residual carotid, and honestly, we were considering alternative diagnoses such as a dissection. So we did an ultrasound carotid on day 3, And that showed us the residual. It didn't show us a flap. It didn't show us any sort of indication that we are looking at a dissection. It did show that there was a residual plaque, and there was less than 50% stenosis of the proximal ICA that was still there. So at this point in time, the two diagnoses, and we were still considering dissection as one given his age and you know the fact that this is a solitary atherosclerotic lesion without evidence of atherosclerosis anywhere else. So so I'd appreciate, Dr. Qureshi, your comments on whether we should be entertaining dissection at all, or does it look only atherosclerotic, or should we, is there anything else that you would recommend doing at this point in time?
So one thing I would mention is that, you know, this has always been very challenging, that what shall we do if there is an intraluminal thrombus in the internal carotid artery? And I think that, you know, you probably have to divide it in three categories. One is if it's occlusive. So if it's occlusive, it I think becomes simpler because the thought would be to actually treat it. You know, whether you're using aspiration, whether you're using a stent retriever, or actually using a combination of both. And then with the understanding that sometimes there may be an underlying atherosclerotic plaque as well. So you may actually have to do an angioplasty or maybe even a stent. When it's actually just partially occlusive, then, you know, I think that as Irteza mentioned earlier, that if it's flow limiting and the symptoms are fluctuating, or you're in a time window to do something, or there's viable tissue, then it makes a stronger case to try to aspirate the thrombus or retrieve it using a stent retriever. But a lot of time is something similar like this one, where you actually have a thrombus that's not even causing up to 50% stenosis. So it clearly is not occlusive. It's not flow limiting. And if anything, it's just a nidus for emboli formation. And I think that, again, there's a divergence of opinions. But most people have, I guess, feel that, you know, trying to intervene in such circumstances, there's always a risk that the emboli can fragment, or the thrombus can fragment, actually causing true occlusion of the middle or the anterior cerebral artery, and the things could actually get much worse. And I guess the general thought is to actually do anticoagulation or even antiplatelets and just wait for the thrombus to resolve. So I think that a lot of practice has shifted, or at least that's what I have started doing, is actually to opt for medical treatment and let the thrombus resolve, and then actually come back and look at the blood vessel again to see if there's an underlying disease process that may warrant a stent placement. I think I have my junior colleague here as well, Dr. Ishfaq. Do you want to comment something?
No, I think I was looking at the MRI, and on the right side, I think it's a watershed infarction in the AC-MCA territory.
So this is actually an interesting point I want to make out, that, you know, infarction that actually appeared to be watershed, you know, people always thought they were hemodynamic. Yeah. But actually, if you look at the literature, you can even have an embolic shower and it would actually cause the same topographic image. And perhaps because the emboli, as they distribute, they end up going to the furthest distribution of the vessel, particularly smaller emboli. So I think that, you know, the topography of infarction to determine the underlying mechanism that caused the infarction has been tricky and has not been very accurate in the previous studies. So that's the only caution I would, or the only cautionary statement I would make.
Yeah, because when we look at these border zone, we typically want to look at the vessel as well. A lot of artery-to-artery embolism does present in this manner. So yeah, I think the next case would highlight that a little bit more. Okay, so thank you for that comment. The patient was discharged with an NIHSS of 8. Unfortunately, his hemiparesis did not improve a whole lot after the procedure. The other minor deficits, like there was a mild element of aphasia and the facial and the gaze paresis, all of those things did get better. So the choice of anti-thrombotics at this point in time, Dr. Irteza, and possibly this is the last question for this case. What would you choose to give this gentleman at discharge?
I guess that all of the workup is pointing towards ulcerated plaque, right? And thromboembolic phenomenon on top of hypoperfusion. So we would treat this plaque as unstable and ulcerated and treat it intensively. Now, the issue is your NIH is high. It's not a minor stroke, and it's not an intracranial lesion. It's an extracranial lesion. So if you followed all guidelines, a single antiplatelet, I typically go with Plavix in poorly controlled diabetics based on some of the literature. So Plavix, intensive statin therapy, and then modify all the other modifiable risk factors. But one thing that might, and then coming to anticoagulation, I don't believe we have good enough evidence to support routine anticoagulation unless there's evidence of intraluminal free-floating thrombus. Then, outside of the guidelines, we have treated patients briefly with anticoagulation, then re-imaged the area and transitioned. But I'd also like to make a quick comment in that I think we're moving away slowly from luminal narrowing and stenotic lesions of carotids, right? So there's a lot of focus upon the actual, the criteria or the characteristics of the plaque itself. And so now we have MR plaque imaging that's available, or PET imaging, which when combined with ultrasound data, if you see evidence of, a necrotic core and you have evidence of intraplaque hemorrhage, we know those patients are high risk for recurrent events. And I do believe the community is slowly now moving away to earlier endarterectomy or revascularization in patients with unstable, ugly looking necrotic plaques. So I think that potentially would be an option in the future, but my bias would be to start with antiplatelets. And
how frequently do you see a single vessel affected like this with the other vessels completely clean?
So increasingly, I've been seeing it here, and I think perhaps Maria and Dr. Suhail, you can comment on this, because I know you've done a lot of the research on the epidemiology of stroke here. The average age of stroke here is 10 to 15 years younger than the West. Yeah. And we have accelerated atherosclerosis. But a lot of times we do see asymmetric, and we're not talking about stenotic disease, right? We're talking about plaque that is unstable, and something has happened that triggers a plaque to be unstable. And on regular imaging, you may not pick up atherosclerosis in other areas. But I'd love to hear your comments.
Which is true if you look for this patient and other patients that we are getting in Dubai community, very young patients with very clean artery, and they will presented with these type of unusual clot in the ICA. From our epidemiology study in Dubai and UAE, and also the Middle East, the paper which has been published with SIDS, we found that the average age of stroke patients in Middle East is younger by 10 to 15 years than the one in the West country, and the intracranial disease plus dissection is more in our community compared to the West country. One question, Maria, if we did an MRI before the mechanical thrombectomy, do you think that you will go for for the procedure or not?
Well, it would depend on whether we find a mismatch there, a diffusion flare mismatch, or if you're doing a perfusion study, ideally we see a diffusion-perfusion mismatch. If there is no, and then like it was mentioned, I think that there's no occlusive disease right now. We are only dealing with a thrombus, which is only partially occluding. So we have in the past treated these patients in the acute setting with anticoagulation, and then switched them over to antiplatelets as we work them up for the underlying pathology. So yeah, I think MRI would have helped us decide whether it was really necessary to go in, or we could have just kind of treated with anti-thrombotics up front and not done the intervention. Although it's a tricky question, because then you're leaving a thrombus there and the patient might still deteriorate. His NIHSS was 13. It was a dominant hemisphere we were talking about. So it was not an easy decision.
So just want to make a quick comment about the choice of anticoagulation versus antiplatelets. And I think that over the last 2 decades, what we have seen is most of the secondary prevention move in an antiplatelet direction. So I guess where there is no controversy is patients who have an ischemic stroke with atrial fibrillation, who sooner or later have to go on anticoagulation. For intravascular thrombus, I think most people still opt for anticoagulation, but I think one has to acknowledge the divergence of opinion that even a dual antiplatelet regimen is also acceptable. The other thing I just quickly wanted to say was that very infrequently, you can see a lesion like this, which is actually a myxoma of the carotid artery. So that's something also to be aware of, that the myxomas of the carotid artery can actually also present like this, and they will actually just have a mass that actually appears in the internal carotid artery. And since the echogenic characteristics are very similar to a thrombus, it doesn't have high echogenicity, so it can actually masquerade like internal carotid artery thrombus.
So then how would you go about differentiating that? That's very interesting.
So I think that you have some very good questions here, I think that the first question is an interesting one, and I think that you will find different answers to that question, and one has to acknowledge that they're all acceptable answers. I think that in the last, people have relied on aspect scale to determine whether there's viable tissue or not, with a reasonable level of accuracy. I think that one has to acknowledge that the plain CT scan actually provides more information that we had initially anticipated. I think in most settings, CT perfusion actually has become the first line to determine if there is salvageable tissue or not. And I think that in terms of intravenous tissue plasminogen activator, I think that the classic guidelines are really based on time. So anything that you're doing beyond using a time-based guideline, it actually is I guess, divergence from practice. So you have to make a good justification. And I saw one of the comments about using FLAIR to actually determine how long, or actually creating a time or estimating the time window based on the appearance on the FLAIR. And that has actually been an interesting concept, because it appears that it takes around 6 hours before the ischemic changes would actually be visible on the FLAIR sequence. So if you're not seeing enough changes on the FLAIR sequence, then perhaps the ischemic stroke occurred earlier than the what we are estimating based on last known normal. Okay. And I think that with the carotid stent placement, I would have to just agree with Irteza that in the absence of a complete occlusion or a flow limiting occlusion, any intervention, the risk may be overshadowed, the benefit may be overshadowed by the risk the procedure will bring, and the benefit may be questionable. So I think that the management that you did, actually medically managing, was the most appropriate step to do. And in terms of etiology, I think that we still have to acknowledge that a large proportion of patients will still have to fall in that category called stroke of undetermined etiology, which unfortunately is a frustrating category, but it still is there. And we have to acknowledge that there are many patients in whom we're just never going to find an etiology. And I think you've already done everything that one could do to find an etiology. I do not think that there's anything additional. One thing that more and more is being done, and in our practice, we actually insert the loop recorders ourselves. So it's actually a subcutaneous small, I guess, recorder that's placed in the fourth intercostal space, and it actually is monitoring cardiac rhythm for a prolonged period of time to see if people actually have this paroxysmal atrial fibrillation. So there may be times when they actually do have atrial fibrillation, but it's so infrequent that you're not picking it up on routine electrocardiographic monitoring, and nonetheless, they do actually have a risk or increased risk of ischemic stroke, and anticoagulation may actually be beneficial. So that's the only additional thing to think about. And again, I do not know whether it would add more to what you already, to the information that you already have.
Okay. Okay, so thank you very much. I think we'll move on to case 2. Dr. Suhail is the president of the MENA Stroke organization and of the EMINS, and he is a consultant neurologist at Rashid Hospital. He will be presenting the second case.
Thanks, Maria, Irteza, and Adnan. This case will be faster than Maria case. Again, the objective of choosing these 2 cases was the month of December. So we took just the 2 cases that we had last month and we decided to present them. Hope we will find an etiology for this case that is going to be also a young patient who has been admitted on the 1st of December 2020. He's a 41-year-old gentleman, Indian, who's using tobacco, no cardiovascular risk factors, presented with a history of 4 days right side body weakness, which had a stepwise progression. So the patient described that he had a right hand clumsiness, then a drop of the right hand, then he started over the next 2-3 days to have more progressive weakness of the right upper limb. So when he presented, his upper limb was more affected and he was able to walk with the support. Regarding his past medical history, he had non-healing ulcer on the right chin for past 4 months, has been advised for some surgery, but unfortunately he was unable to do it as he was unable to support financial. For that reason, he denied any oral or genitalial ulcer or any kind of skin disease. So this is from his file in 2020. The picture was at the time of the admission. He presented in July with a chin ulcer in the right leg, non-healing, and with a cellulitis around that ulcer. On examination, there's a clear tortuous veins over the right side of the leg, along with infected ulcer 1.5 centimeters. This is from the vascular surgeon documentation. Ultrasound Doppler was done at that time, showed no deep venous thrombosis, had superficial venous insufficient, which has been also repeated during his admission in December. Patient advised for a surgery, endovascular, but he was unable to do it at that time. So going back, so this is 44. For history of progressive upper limb weakness, presented with severe upper limb weakness with walking with a support. So CT brain was done in the emergency, which showed no hypertension sign, no major stroke there to explain his weakness, but he had this area, Dr. Irteza and Adnan, left subcortical semivalley area with hypodensity with no mass effect. So you can see it there. It's very common in our community, Adnan. Nowadays, we are getting patients from sub-Indian continent with neurocytic causes, but there's no calcification. Was this in that area? Usually they presented with the seizure, but this guy presented with this hypodensity area. So an MRI was done. He came overnight, so MRI done next morning, which showed the following. Flare sequence, diffusion weighted. Clear hyperintense signal, diffusion restricted, ADC restricted, bilateral subcortical area. Involving both hemisphere, left more than the right. And it's very clear that it's an acute, as his presentation was 4 days, and you can see some changes on the flare. So the question for Dr. Irteza, What do you think about the possibility of etiology in this guy? Is it cardioembolic, large artery atherosclerosis, or others?
Yes. So it's interesting. So you have bilateral. So whenever you have bilateral presentation, you're always thinking about a proximal source. And so cardioembolic or aortoembolic is a potential option. Some of these lesions are within the what would say watershed territory, and as was talked about in the prior case, you know, the watershed area can represent both embolic as well as hypoperfusion. But because it's bilateral, and I believe maybe some posterior elements as well, I would look for a more proximal source as a possibility. So either a problem with the actual fluid, like a hypercoagulable state, is another option as well.
Agree. So we did immediately a CT angio for this guy on the same day. CT angio was reported normal. From usually our protocol is from the aortic arch ascending, transverse and descended, then going to the large vessel in the neck, bifurcation area, then going up to intracranial disease. This is the protocol that we are using. You can see that there's a small clot there, but that's not a clot. It's just a calcification that he had there. An ultrasound was done. There's no high grade of stenosis in that area. The other view of the coronal and sagittal showed a small bulb atheroma is there. We thought about dissection. Ultrasound was done. There's no evidence of dissection in that area, and that doesn't explain the other hemispheric involving or the subcortical pattern that this guy is having. So CT angio showed just a small bifurcation left side, atheroma, non-significant. Ultrasound showed no dissection with a normal blood vessel intracranial wise. And this is again same things, Irteza, when you said young population with very weird presentation. Adnan, any comments about his CT angio?
So I think that first of all, I mean, the fact that there is some atherosclerotic changes in the internal carotid artery in somebody who's only 41 years old, one has to start thinking about premature atherosclerosis. And I think that the fact that a patient had an ulcer in the upper extremity may not be unrelated. So there may be a relationship here that a patient potentially could have a peripheral arterial disease as well. And to put it all together, I think that one should also consider thromboangiitis obliterans when the patient actually uses tobacco regularly. And thromboangiitis obliterans, in addition to actually involving the upper and lower extremity, there is actually a cerebral variant of it. So they actually would involve the cerebral arteries, both extra and intracranial artery, and then sometimes even the internal jugular veins. So that's the additional thought that I would have. And I think that looking at the topography of infarction and trying to determine the etiology, I think one just has to be a little cautious, because the topography of the infarction may not accurately actually predict what the underlying etiology is.
And it's very interesting that he came with this progressive weakness. It's not a sharp. He came with a distal right arm finger drop weakness. Then he came over 4 days, which is atypical presentation in any embolic type of stroke. So just to carry on his investigation, a vasculitis workup has been done. Lupus, anti-beta-2 glycoprotein, anti-cardiolipin, anti-DNA strand, rheumatic factor, any anti-neutrophil, everything came negative. Thrombophilia, protein S came low in this patient, and the lipid profile was HDL only low there. He's not diabetic, no inflammatory markers. So do protein S in these pattern of arterial disease is have any indication in this case, Irteza?
So, yeah, go ahead.
Yeah, Adnan.
Okay, so I think that in the 1990s there was a lot of interest, as you know, the protein S deficiency, protein C deficiency was identified, whether it may actually have a relationship with ischemic stroke. And I think that most of the studies that looked at that found that protein S deficiency or protein C deficiency, while was a risk factor for venous thromboembolism, its role in arterial thromboembolism could not be confirmed. So here, one actually is that whether the protein S levels have anything to do with the ischemic stroke or not. And secondly, is it a sustained phenomenon or a temporary phenomenon? So by definition, to actually declare somebody who has protein S deficiency, a repeat level must be drawn at a month after the phenomena to document whether the levels are indeed still abnormal or they've actually just normalized and it was a temporary phenomenon.
Irteza?
I agree. We typically would not diagnose this with a level. We would repeat it, and usually we do not consider it a risk factor for arterial stroke.
So are you doing this because if you look for the AHA guidelines and others, it's part still of their protocol when they are doing the stroke workup for a young sending for protein S, protein C, or do you keep it only for the venous thrombosis and the others, Irteza?
So basically, the way it's ordered is it's a hypercoagulation panel that it's usually sent off from the very beginning. Usually the residents or the juniors have already sent it off. And I think that's based on the guidelines. But whenever we speak to the hematologists, a lot of them basically say, well, we have no evidence of venous thrombosis unless you're saying it's a paradoxical embolus. In the absence of that, then they would like to see a repeat level in a delayed fashion. So over the years, I agree with Adnan. I have not really felt that this is a major issue, but it is tested routinely.
I agree. So very interesting when looking for the old record of these patients and looking for the platelet count. This patient is having a very high platelet count where will make him in a criteria of thrombocythemia, where his platelet is above 400, which is almost double the normal range of the platelet count, which was in July, August, and at that time of the presentation. Does that, Adnan, explain his watershed type or embolic type of stroke that he had?
I think what you're looking at is an inflammatory response here. And whether that inflammatory response is secondary to an infection that we do not know about, or is it related to the ulcer in the hand that actually is infected? Now, there is actually a relationship between infection and stroke, an ischemic stroke. And it seems like people who have sepsis or another bacterial infection have a higher risk of having a stroke. People who have respiratory tract infections, viral and non-viral, have a higher risk of having ischemic stroke. And surprisingly, the increased risk of having ischemic stroke is up to 90 days after the onset of infection. So it's not, even if the infection has resolved, there somehow seems to be an increased risk that persists up to 90 days. And then the question becomes is what actually is the mechanism underlying this increased risk of actually having a stroke. And I think that all of this has been brought to the forefront because of the relationship between COVID-19 and ischemic stroke.
Yes.
And the whole concept of what they call as pro-inflammatory thrombosis. So essentially, inflammation is the first process and the thrombosis is a secondary process. And again, there are further research that shows one is actually hyperaggregability of the platelets that has been shown in people with viral infections, and also an excess fibrin polymerization, which is what has been shown in COVID-19. And what causes, why there is excess fibrin polymerization with infections, it's not clear. And why there is hyperaggregability of platelets after infection is also not clear. But what that it translates into is that whether one antiplatelet medication is superior to another in such a circumstances, or whether anticoagulation is superior to antiplatelets in such circumstances. And obviously, the risk is really for the first 90 days. So whatever the regimen we think is superior, probably the treatment really should focus on the first 90 days.
Very interesting. And as Irteza said, when you have a resident that they will send for different tests, my resident sent for herpes simplex virus, which came positive in this patient, IgG and IgM. What does that mean? Why did she send for that one? I'm not sure, part of his workup, but that came positive. Other infectious like syphilis, HIV, hepatitis C and B were negative. His ESR CRP is negative also. So does herpes simplex, and that was a question to Dr. Suhail next morning when the result came, shall we treat him with antiviral? Shall we give him treatment for the herpes simplex? Because of this, despite the patient is not encephalopathic, he's not having any viral sign infection. What do you think, Irteza?
So, I mean, it's IgM along with IgG, so an acute event has occurred. So I was wondering, was there a thought that the rash was herpetiform in any way, superimposed on the venous ulcer? I didn't get that sense.
No, it wasn't seen by the plastic surgeon, by the vascular surgeon, and it has been there for almost more than 6 months.
Wow, interesting. I mean, this is not consistent with HSV encephalitis. The question, though, is this systemic HSV or I don't know, false positive? I'm not sure. But okay, if we reconfirm that it's true, and we have a patient who has thrombocytosis, elevated white blood cell count, looks like an infected ulcer, and now also has HSV, anything that could promote inflammation, I guess what would be the downside to treating it? That would be my approach to it. Yeah.
So that was the question to the IDU, and the answer was repeat his test, which we were waiting after discharge to do it for this patient. Just going there to finish his stroke workup, transthoracic echo, transesophageal echo, and 24 hours telemetry were negative. No PFO bubble study was negative, no valvular disease, and no sign of arrhythmia. So going back to the same case of this patient, a young patient, 41, no risk factor, coming with these type of subcortical white matter disease, bihemispheric, left more than the right with the progress symptoms. Patient was discharged home after with a major improvement in his deficit. He was only having mild finger weakness, independent mobility, and scheduled for a vascular surgeon. The question is coming back again, like Dr. Maria Khan, etiology of stroke and the choice of anti-thrombotic. What do you think, Adnan and Irteza? Is it post-inflammation? Is it related to his thrombocytosis that he's getting? Is it HIV? Or it is young patient with early atherosclerotic disease, despite he doesn't have any risk factor?
Right. So, I mean, I think there are multiple questions that have been raised. So possibilities that come to the forefront based on his presentation is a para-infectious, because it looks like he has an ongoing infection, a para-infectious inflammatory state. So the primary state should be addressed. I think otherwise my choice would be antiplatelet and vascular risk factor control. And then the final question is, okay, could all of this truly be tied together as some type of thromboangiitis, and whether that needs to be addressed from an inflammatory standpoint? That would be my take.
I think in terms of the etiology of stroke, I think that either we have to say that the patient has a stroke of underlying etiology with a possible relationship between an inflammatory reaction that preceded, and there is probably an underlying infection because of the ulcer, and somehow that's why the risk is actually increased. or this is all related to use of tobacco, and it's a form of thromboangiitis obliterans, where you have extracranial carotid artery disease. You are probably, if you have actually disease of the upper extremity blood vessel, which is pretty classic with thromboangiitis obliterans. And then whether actually, if that doesn't fit, then should we actually do a longer monitoring by putting an implantable loop recorder? That could be considered. And in terms of choice of anti-thrombotics, I think that we haven't seen anything that would convince us to use anticoagulation. I think that probably antiplatelets, whether we want to use a single antiplatelet or a short-term course of dual antiplatelets, would both be reasonable. And I think that unless we can see more evidence of something that warrants an anticoagulation, probably antiplatelet is the way to go. And I think that you bring out a nice slide about protein S deficiency, which again, the question becomes is that even if there is a documented deficiency that's persistent on a repeat exam or evaluation at 1 month, whether it actually is truly related to the ischemic stroke. But obviously there can be some relationship with the venous ulcer. I think that definitely is something that warrants further evaluation. And I think I actually have a question whether there was any evidence of ischemia in the upper extremities. So essentially the capillary refill times were delayed, or there was any other clinical symptomology that would suggest that there was actually active ischemia of the upper extremity, whether they had claudication on, I guess, voluntary use. So that may be some additional questions that one can look into.
Yeah, there's no history. He has been seen by the vascular surgeon. They believe these are venous ulcers that he had in the lower limb. Biopsy has been taken. There's no insufficiency of blood flow to the upper extremities. Neither patient was complaining or giving a history of any type of heaviness or weakness or claudication before this event happened. One of the things that unfortunately we were unable to do for these young patients because of financial issue is doing a conventional angio. Do you think, Irteza, that you will go for a conventional angio for these bilateral hemispheric subcortical white matter ischemia?
So if we're considering a differential of potential vasculitis or inflammatory state, then it would be indicated. The interesting part is, though, we do see signs of extracranial disease, and with the overall inflammatory markers and everything, I'd actually be more interested if there are other signs of systemic atherosclerosis before central, CNS angiitis. And then the clinical presentation, I guess some questions are here as well. I'm just looking at people, why didn't we do a CSF exam or look at other things? The clinical presentation is stepwise stroke. We're not dealing with encephalopathy or prodrome of headaches or other things that have been going on for some time. And actually the patient is improving in the absence of immunosuppression or other things. So really not thinking on the lines of a CNS vasculitis, either primary or secondary, but I think we would want to look at the vasculature as a whole and the rest of the body systemically. That would be my thought. Yeah.
Agree, Adnan?
Did we check the DVT ultrasound of lower extremity?
So I think that my colleague, Dr.
Yes.
Did we check the DVT ultrasound of lower extremity?
Yes, it's done twice. It's done in July and during the admission in December. Has been looking for the deep and superficial. Patient has a superficial insufficiency. That the report of the vascular lab by the vascular surgeon, and they offer him a vascular intervention treatment, but unfortunately he was unable to do it. Yeah, but there's no DVT, nothing.
Just one word about cerebral vasculitis. I think that the cerebral vasculitis are usually divided into two groups. One is which involve the medium-sized arteries, and the other one that actually is limited to the small-sized arteries. And as Irteza mentioned, that the cerebral angiography is helpful if the vasculitis truly involves the medium-sized arteries. So if you don't see abnormalities on the cerebral if you see abnormalities on the cerebral angiography, that's good. You may actually be closer to making a diagnosis. If you do not see abnormality, that doesn't exclude vasculitis, because it may just be limited to small arteries that are just not visible on a cerebral angiogram. I think the other point Irteza made was a good one, that cerebrospinal fluid analysis is also helpful, because people who have cerebral vasculitis usually have evidence of inflammation in the cerebrospinal fluid. So essentially, the initial screening, in addition to the clinical syndrome, if you're going to do cerebral angiography, we may have to supplement it with a cerebrospinal fluid analysis as well, if you're going to walk the path of vasculitis. I think that in the end, if there is a suggestion of vasculitis, probably best to confirm it with a brain biopsy, because once we give somebody a label of vasculitis, that label is going to stay for them for the rest of their lives, and they're pretty much going to be condemned to immunosuppression. So I think a higher level of diligence is necessary upfront before we start them on that path.
Clear. So I will ask Dr. Maria to join us. Dr. Irteza and Adnan, I have a list of questions from the audience. Thanks for sharing discussion these cases. We made a great, we had a great participant during this session. We exceed 1,000 attendees. So the first questions to Dr. Syed, do you think Berger disease in a young man with a case of vasculitis was positive there?
So thromboangiitis obliterans, it's always a possibility in young people with tobacco use, but usually we're seeing multiple vascular territories with occlusive symptoms, upper extremities, other signs or symptoms. I guess a de novo presenting with one vessel, I haven't seen that. Typically it's multiple vessels simultaneously.
Okay.
So
another question from Dr. Rosario, possible of embolization from the left carotid plaque. Most lesions are on the left side, but we have some on the right side. So it's not just coming from the left carotid. Is that correct, Irteza?
Yes, it's an asymmetric pattern, and the burden of the disease was on the left side. So no doubt that probably led to some embolization, but we could not explain the bilateral and the anterior and posterior division of it. It was more diffuse than just one vessel.
I'm answering here, Dr. Munir. Did you perform TE looking for plaque on aorta? Yes, that's part of our protocol. Usually the TE, they will look for the aorta part, and also the CT angio, we are including the ascending, descending of the aorta. Dr. Adnan, question from Dr. Lama. Do you think smoking among people in a high proportion among young age will lead to stroke at this age, at age of 40 or less?
So I think that, cigarette smoking and the relationship with, in form of a thromboangiitis obliterans. So if you see it in younger individuals, at least here, one of the things that actually, so if they do cigarette smoking in addition to cannabis use, there seems to be accelerated form of thromboangiitis obliterans. So they would end up having these changes at an earlier age. And we actually saw a patient last week, which we thought had a classic description of thromboangiitis obliterans. And that patient, in addition to a long history of smoking, she was actually doing vaping as well, which is actually a form where you inhale a high concentration of nicotine. And that has become very popular in the United States recently, and seems like there's a lot of problems being described because there's such high concentration of nicotine that you're probably starting to see a more accelerated response to all kinds of things that we used to see with cigarette smoking over years. We're seeing it in months.
Clear. Regarding lumbar puncture, when you mentioned that, Irteza, any specific exam in the lumbar puncture you would do, or just the routine one?
So no, typically just routine, looking for signs of inflammation, ruling out infection, because if you are going down that path of vasculitis, you want to make sure you're not missing an infection. And then it's really dictated by the clinical presentation, but routinely, just the routine screening for infection and meningitis, encephalitis panel and protein. That's where we usually start off. But I always store one test tube, 10 cc's.
Okay. So Maria, I don't have anything to add. Do you want to say anything?
Okay.
Yes.
Okay. So nothing really. I really enjoyed myself. Thank you very much, Dr. Irteza and Dr. Qureshi. I learned a lot, and I hope our audience learned a lot, and looking forward to the next one already.
So 30 minutes, Dr. Adnan Qureshi, Dr. Irteza, feedback about the first webinar in 2021 with MENASO.
Well, I learned a lot myself, so thank you very much for having me there. I think that some of the questions that came to the chat box were excellent, and I hope that we were able to answer most of them, but evidently the participants are very engaged and very knowledgeable. Very impressive questions.
Irteza?
Likewise, I really enjoyed myself. Thank you so much. It was a great opportunity, and I hope we can continue this through these times until we can meet together in person, inshallah. But until then, we should continue to meet like this and learn from one another. Thank you so much.
So thank you for everyone. Thanks, Dr. Irteza from Cleveland, Abu Dhabi. Thanks, Dr. Adnan Qureshi from US. And thanks for Dr. Maria. Tonight, you had Suhail A Rukn with you. Next month, inshallah, from Cairo, Ain Shams University and Cairo University, we will have distinguished speakers from there with cases, challenge cases. It will be on the 16th of February. Put it in your calendar, please, and see you there. Assalamu alaikum.